already covered the basics of respiratory physiology, different terminology used for in mechanical ventilation, along with the different modes we already covered till now that. And today we'll, after that basic idea about what is ventilator, how it works, what are different modes are there, then we'll try to move to the next level, how to initiate the mechanical ventilation. And after initiation, how to manipulate. The main thing what we are doing ventilation is for ventilation and oxygenation. So how to do that manipulations on the ventilator regarding your oxygenation ventilation status. Along with that, we'll cover disease-specific ventilation as well. So the general principles of ventilation is you ventilate a child mainly when child is having inadequate oxygenation or child having ventilation. Ventilation is about CO2 or child is not able to protect the airway. So these are the main indications for your ventilation. So what your aim is, you need to provide sufficient minute ventilation to maintain the CO2 to the normal range. And you need to provide at least minimal oxygen to meet the delivery of the metabolic needs. And always try to restrict your pressures to minimize the secondary lung injury. That is called ventilated lung injury. You should not overdo the ventilation. It can damage the lungs. So always try to minimize whatever things you need to give for a child. You need to minimize. Accept the little lower settings, lower targets as well. Not about settings. So to maintain the lower pressures. But most important thing is you need to optimize the workout breathing of the patient and need to make him more comfortable on the ventilator. So that the main targets are main goals for mechanical ventilation. So one is to provide adequate oxygenation and adequate ventilation, and with minimal possible pressures to minimize the risk of secondary lung injury. And also you need to make sure that you are optimizing the patient's workout breathing and his comfort levels. So with this thing, we'll move on to the actual topic. So first of all, I want to know from you people that how many of you are already using the ventilator, and when you're putting the child on the ventilator, so what are the settings you're going to set on the ventilator? What you can adjust on the ventilator? So what are the different parameters which you can adjust on the ventilator? So already we have covered this in the modes also, but I just want to know from you what are things you can adjust or you can set ventilator.
PIP, PEEP, FM to tidal valve, these are some of the parameters.
Okay. That's all?
There are more.
Yeah.
Like inspiratory time, TI-IE ratio.
Okay, so you organize them into 3 to 4 groups. So what is the parameter related to pressures? What are the parameters?
Like peak inspiratory pressure, PEEP.
Yeah, you can, in pressures you can control PEEP and PIP. In volumes, what you can control?
Tidal volume and flow.
Flows in the new ventilators, it's very difficult. I think in the old ventilators you can control the flow, but with the new ventilators it became very easy for us not to touch the flows, directly control the volumes rather than controlling the flows. And then you need regarding timings. What are timings you can control?
P ratio, T inspiratory time.
Yeah, you can control rate, I time, and I ratio. Yeah. And other parameters are like you can control FiO2, and you can control slope of your PIP rise. What is it called? What is the name of that control you do for increase or decrease the slope of PIP? So T rise. And other thing is trigger. So these are the parameters which you can control on the ventilator. So we'll move on to the initial settings, what you prefer for normal lungs. How many types of lungs we have? When you're ventilating a child, what are the type of lungs you will expect?
Normal, low complaint, high.
Thick lungs, low complaint lungs, thick lungs.
So normal lung, low compliance lung, and last one is
More resistance. More resistance.
Dial.
right. So we'll start with the first normal lungs. So these are normal initial settings for normal lungs. It depends on the age group as well, and certain parameters are common for both. So we'll start with the tidal volume. So tidal volumes normally will give at a range of 5 to 8 to sometimes 6 to 8. That's what it is constant for the any age group. And what is the weight you need to take to calculate tidal volume? Which weight? Current weight or ideal weight? Hmm. Okay. You need to choose only two here. What is our current weight? What is ideal weight?
Ideal weight. Ideal weight.
Always go for ideal weight. So there are very few instances where you need to use something, not in ventilation, anything, drugs also, only for current weight. Very few examples are there. But rest of all times when you told ideal weight, it is fine. So next parameter is PIP. How to set the PIP? Either any fixed number like I given here 16 to 25. Either any fixed, how to choose it 16 and it is 25.
Chest rise.
Yeah, for the chest raise, where you're getting adequate chest raise, and what other thing you have to look for apart from chest raise clinically, you can something you can see in the monitor as well. It's not on the your vital monitoring, it is the ventilator monitor, ventilator screen. So what is the parameter to look for? Why you are giving PIP for a change? First of all, what is the need of PIP? When already giving a pressure of PIP, why you want to give PIP? What is the function of PIP? Come on, man. It is to generate
To
a
overcome the resistance.
yeah, it's to overcome the resistance and to distend the alveoli. That is called your generating tidal volume.
Yes.
Yeah. So what determines your PIP now? Apart from chest rise, how the changing chill is getting chest rise? Why you are looking for chest rise?
To look for compliance. Yeah, the lung is expanding.
Talking about compliance or resistance here at all. I am talking about how to set PIP in initial itself. When you're looking for chest rise, what you're looking for actually?
Alveolar expansion.
Yeah. How much of the volume of air is pushing in? That's the tidal volume. So when you have a ventilator which can show directly what the tidal volume generated to the patient, now we are not relying on the chest rise. So you have obvious evidence of objective evidence. Chest rise is subjective, but objective evidence you have is tidal volume. So you have to see on the ventilator monitor what is the tidal volume generated, and you need to optimize the PIP to the tidal volume what you need. You need a 5 or 6 or 7 or 8. It depends on your need. And in different conditions, you will target different tidal volumes. We'll see it later. But for normal lung, I'm telling you. So for normal lung or any other lung, it's basically what the tidal volume you want to be generated, and you need to adjust your PIP to meet the tidal volume. And objectively is tidal volume, subjective is chest rise. So PIP is physiological PIP. Physiological PIP is around say 3 to 6. We'll start with 4 to, usually we won't go below 4. We'll start with 4 to 6. Usually 5 or 6 we are going to keep for normal lungs. And rate is physiological, so you should not cross any physiological rates. You start with the on the lower part of the physiological rates, not in the middle also. You have to start at the lower, and depending on your CO2s and oxygenation, you need to adjust the rate. And inspirated time in newborns is particularly they will be more worried about inspirated time, because they won't give more inspirated times in newborns, and it's depending on the preterm status. They'll be like it will start with the 0.3, 0.4 seconds maximum. They'll go 0.45 to 0.5. They will not cross that in the newborns. So the 0.3 usually for the extreme preterm, 0.4 for term children. This is what in between they'll keep it for the other in between late preterms or normal preterms. So why this is important in spirit time? In spirit time determines your tidal volume.
Oxygen. Tidal.
Tidal volume. So because the pressure into time, that is what the determinant of tidal volume. If you give more tidal volume in spirit time with same pressures, you'll generate more tidal volume. And if you cut down the inspirated time with the same pressures, you can decrease your tidal volume. You can check it when you are operating ventilator. Just go and check it. So shorter I times with same pressures will decrease the tidal volume. So we'll see how it's going to happen. That we'll see in the next slides. So these are the inspirated times for children. Infants 0.4 to 0.6. Toddler 0.27, 0.9, and adolescents 0.9, 1.2. These are rough things. It all depends on what type of underlying lung disease you are dealing with. It's the normal lungs. This is the what we will start initially, and we'll try to manipulate it according to your oxygen ventilation status. And if you're giving pressure support, usually we'll start with don't start with the lowest pressure support. We'll match it with the PAP, and it should never be equal to the delta P. The delta P is PEEP minus PAP, and your pressure support should never be equal to delta P. That's one thing you should learn. If you're giving pressure support equal to delta P, then there's no point of decreasing the rate and allowing the child to breathe. So your support should be always at least minimum 2 less than the delta P. So your PAP, say your PAP is 20 and your PEEP is 5. So how much is the pressure support you're going to keep?
13.
So roughly 13, and should not cross 13. You can start with 10 also. You don't want to give full support, you just come with 10. If the patient is getting agitated, he needs more support, then you can increase support. But you should never go beyond 30. That's what I'm telling. So you can start at any point, but you should not cross 13 in that particular patient when you have PAP of 20. In FiO2, initially we'll start with the 100% till the child made the saturations, and will rapidly wean. It's not slow wean. So there is no slow weaning of FiO2. That's what I'm telling. Many times I see you reduce FiO2 by 5 over 3 to 4 hours. There's no use for that. It is not the FiO2 which is going to maintain the saturations. It is the pressures and your times. That's what more important than FiO2 for us. So don't concentrate on FiO2 slow weaning. So you need to wean it rapidly. Once it's less than 60, then you can try weaning slowly. But our target is main target. Once you optimize the pressures, you're able to maintain the saturations well, quickly drop. From 100, you can drop to 60 abruptly. You need to change it to 70, 80, 90, like that also. You just drop it. And flow triggers, usually in children, we use flow triggers. We don't use pressure triggers that often. But very extreme patients where they got agitated more and they're triggering, auto-triggering with the flow triggers, even the maximum flow trigger, what you said, even despite that they are having very high rates, then we'll try to restrict the rates when you'll go for negative like pressure triggering with high pressure trigger. And we have discussed yesterday that in MACED it will be numbers, and other ventilators it will be in numericals of 0.25, 0.5. This is like actually liters per minute. This is not the percentage. In MACED it's the percentage. And other ventilators it will directly measure the volume. So how much of the volume they need to generate. So usually we'll start with in infants, you need to keep on the little lower side because they will not be that much able to generate that much volume. So the trigger should be like high sensitive triggers. In newborns and infants, it should be high sensitive triggers. When you move on, you will decrease the sensitivity little extent, because if you keep the very high sensitive trigger for adolescent, you can easily trigger it and it can become auto triggering. So in MACED, it will be like numbers. You choose the number 4 to 6 between for younger infants, 3 to 5 for other infants, other children. So younger infants 4 to 6, 3 to 5 for. If you keep 5 for any child, it is fine. Just forget all these things. If you have a MACED ventilator, just to keep 5. And if you have a GE ventilator, other ventilator where it is displayed in terms of liters per minute, then you can just choose 0.5 for infant, 1 for child, 2 for adolescent. 0.5, 1, 2. Just remember that these three is enough. And you need to keep adjusting that flow triggers based on the child, either the child had auto triggering or child had some triggering at all. So that is the manipulation you need to go to do. And prayer support cycling is what I do. For cycling, you tell that if the prayer support reaches 25% of the peak flow rate, you cut down the inspiration, go back to expiration. So usually we'll start with 25 and we can decrease it depending on what type of lung you're ventilating. So around 20 to 25 will keep. There's a normal, for normal lungs, prayer support will keep around 20 to 25% of the cycling. This cycle. So this is what the parameters you're going to set for ventilation in any child. You say low competent lung, high resistance, normal lungs. These are the parameters you're going to set. And depending on the lung variety, you need to choose what the parameter and how much you need to go. Any doubts in this slide? I think this is a must slide for everyone. So this is what you need to do the initial settings, because many times you're going to ventilate little normal to mild disease lungs when neurological conditions, surgery. So these are not normal lungs only. So only very rarely we're going to ventilate extreme lungs. So we'll also discuss with that about extreme lungs. And for normal lungs, these are the common settings. And this is like, you need to just remember this. There's nothing too much to understand. This just you need to remember. These are the things we need to keep when you're ventilating, starting on the child on the normal ventilation. Once you start the child on these settings, what are things you need to monitor? It's okay. We started the child on whatever may be the lung. You start on these settings. You don't know what is the underlying lung. You know, these are the normal parameters for any child. So, okay, you start on these settings. And what are the things you need to look for?
Tidal volume, sir.
Yeah, it's okay. You put on tidal volume control. No, you adjust the settings so that you get the desired things initially itself. So if you are putting on pressure control mode, you're going to control PIP, but the PIP, what you're going to set initially itself is to match the tidal volume. You cannot relax on that. So I am not asking about what are the things you need to monitor in this ventilator parameters externally. FiO2. Yeah, you need to monitor saturations.
Oxygenation and ABG blood gas.
ABG blood gas, oxygenation.
Heart rate. Heart rate.
O2, yeah, why heart rate? Yeah. So first thing you need to monitor is work of breathing. So how the child is coping up with your ventilation, whether you're able to adequately support the ventilation. Any child having increased work of breathing on ventilator, that means that child is doing more work than ventilator. So that is not good for the child. So the main purpose of our ventilation is to take care of the work of breathing and to make the child comfort. When you are not providing that comfort to the child on ventilator, then means you are not supporting the child adequately. So you need to more support. So exactly, the heart rate increase can be because the child has got agitated because he's doing more work of breathing, or because of the tube in position and with the analgesia, less analgesia and less sedation, he'll be agitated. That's when we increase for heart rate. And you monitor SpO2 and you monitor ABG. And one more reason for heart rate monitoring is your positive pressure ventilation will decrease the venous return, because there is a lot of pressure in the intrathoracic pressure is increased. The venous return will be compromised. So the preload on the heart will be reduced. So it can cause unstable hemodynamics in a child already, because you're ventilating, you're going to ventilate sick children. So that's why you need to think to watch for hemodynamics as well. And most important thing, you need to facilitate ventilation. So you need to have good adequate sedation analgesia. So once you put on intubated child, put on ventilator, and if you don't start adequate analgesia and sedation, the child will waken up from that whatever neuromuscular blockade you given, whatever sedation you given during intubation, and he will start fighting with the ventilator. That will be very problematic. It can cause a lot of asynchrony, and it's like child will be get agitated, and he can pull off the tubes, and he'll basically resist with the ventilator. So that we should not allow. And for that, you need adequate analgesia and sedation. And the common analgesia and sedation, what you could totally use is fentanyl, which is more of analgesic than less sedative. And you need to add something for the sedation purpose to that. And for short-term ventilations, fentanyl is enough. For long-term ventilations, you need to add midazolam for that fentanyl with midazolam. And in case of your obstructive airway diseases and hemodynamic unstable patients, because fentanyl and midazolam can cause hypotension, and so you can try ketamine infusion, so which is a good analgesic sedative with bronchodilative properties. And recently, dexmedetomidine is moving ahead on the other sedations because it can provide decent sedation with acceptable levels of analgesia. But if the child is not getting that much analgesia with dexmedetomidine, you can always add an opioid like fentanyl to that. So ketamine is a good analgesic, good sedative. If you don't know anything, start ketamine. The only problem with the ketamine is it will increase secretions. So for that, you need to give anticholinergic drugs like glycopyrrolate to facilitate the ventilation. And for all stable children, you can even easily try fentanyl with midazolam combination. And dexmedetomidine is a recent one. You can try with that also for short-term ventilations. The most important thing is you need to rotate. The rotation policy should be there. You cannot keep continuing same sedation for 10 days, 12 days if the child is having long-term ventilation. So for every 5th day, you need to rotate the sedation. So if you are on fentanyl midazolam, then you need to switch over to dexmedetomidine. And after 5 days, you can switch over back to fentanyl midazolam again. If you are on ketamine, switch over to either fentanyl midazolam or switch over to dexmedetomidine. This is why the sedation rotation comes. And the second most important, sedation holiday. So mainly to prevent the wear. So you need to stop sedation every day in the morning, unless there's a contraindication like raised ICP. Our child is having severe ARDS and he's getting desaturation when you stop sedation. That is the only 2 contraindications for stopping sedation. This is called sedation holiday. So every day you need to stop the sedation, allow the child to wake up and examine him. And if child is getting agitated, then you have to restart the sedation again. So we monitor the child, and after monitoring the child, we found that child is having either normal oxygenation, normal ventilation, or child is having low oxygenation and high CO2. So you need to do some adjustments for this. And what are the adjustments we have to do for this? We need to see. So what are strategies to increase oxygenation? So what are the things you can do to increase oxygenation?
FiO2, sir.
FiO2.
TI
High time.
time.
Inspiratory time.
Inspiratory time.
PIP.
PIP. PEEP. So not only all the ventilator things, you need to do some non-ventilator things as well. So you need to improve the ventilation and dead space.
Position.
You need to improve circulation first. You need to, if without improving circulation, you don't get the perfusion to your lungs. So you need to give volume replacement immunosuppressants, and you need to maintain adequate hemoglobin. So these are the other vital things, not only manipulating the ventilator. So you need to provide all these things for the child. Then the most important thing is in the ventilator, you need to increase the mean airway pressure. What is this mean airway pressure? I deliberately skipped this. So I don't want to discuss it there. So mean airway pressure is simple terms. I don't want definition. I don't want formula. So what do you want by mean airway pressure?
Average pressure in the Sir, is it average pressure in the airway?
The average pressure, because during inspiration, what is the pressure you have? During inspiration, what is the pressure you have?
Negative, sir.
No. On ventilator, I'm not talking any other thing. I'm talking about ventilation. Positive. You are on ventilation. What is the
Heat, sir.
during inspiration?
PIP.
PAP. What is the pressure during expiration?
PEEP.
PEP. Yeah. So you have difference in two pressures here. So that's why you need to average. Sorry. So then finally you have your FiO2s and you can increase the I time. And finally, when your conventional ventilation is failing, you can go for a HFOV or ECMO. So these are the strategies you need to follow in the order to increase your oxygenation. So first optimize the other things. Don't always look for the ventilation to optimize oxygenation. So you need to have other parameters under control before you start manipulating on the ventilators. And remember one thing, never ever increase FiO2 just to increase saturations, because you are breathing you are breathing at 21% FiO2 and you are getting normal saturations. You should think why this child should require high FiO2 to maintain oxygenation. What is inverse ratio of ventilation is? What is the normal I ratio?
1:2.
You make it reverse, 2:1. Your I time is more, E time is less. So that is called inverse ratio ventilation. So you, just to give more inspirated time, that's all. That's what inverse ratio ventilation is. And FiO2 is the last thing you should touch when you are dealing with oxygenation issue. And is the first thing you should drop when you get adequate saturations. There are little exceptions for this. One is PAH. PAH is the one case where you need to give little higher FiO2s because there is no lung problem there. It's a problem with the vasculature. So there it needs, because hypoxia is stimulator for worsening PAH, vasoconstriction. So that's why you need to give more FiO2 just to dilate the vessels there. So that's the only exception for our rule. All other normal or abnormal lungs, the main target is you should not touch FiO2 first, and if SATs are maintaining, it is the first thing to be dropped rather than the pressures. So PO2 is directly proportional to MAP and FiO2. So MAP is an average pressure. So what is this graph? Pressure time curve. Exactly.
Pressure.
So now I am going to move my cursor. So you need to tell what I am pointing towards. What is this pressure?
PEEP.
Yeah,
PEEP.
this PEEP. What is
PIP.
PIP? PIP. This is PIP. What is this slope? Rise. So what is this time from here starting of rise of T to
Inspiratory TI.
that is inspirated time and this is expected time. I think everyone is clear here. So what is map is? The map is the area under this curve. So take one cycle and this is this expiration. So this is the one cycle, and in this you need to draw the area under this curve. This area is mapped. So you are averaging. This is the PI. This is the project during inspiration. This is the project during expiration. You are averaging. You cannot just subtract, add them and divide by 2, because your I time will be different, E time will be different, and the pressure exposure to the lung during inspiration and expiration is different. So that's why you need to make an average. There's a formula for this. So this is the formula. If you exactly want to calculate map, this is the formula. So no need to worry about the formula. This formula is you just multiply PAP into I time, PEEP into E time, because that is the pressure which is going to be there during the duration, and you divide it by total time. That's all. So I time into PAP, that's the pressure during inspiration. E time into PEEP, that's the pressure during expiration, and divided by total time. That will give the average map, average pressure for you. So how to improve dead space is by cutting your ED tubes, by improving your ventilator tubings. You can just disconnect some of your ventilator tube, extra tubings. You cut down the size of the ventilator tubings as well. This is what we'll do for improved dead space. Yes, that area under the blue shading is the area under the curve, which is map. And the main question is now how you can increase map. Already I showed in the graph. You just need to read 111.
We can increase the PIP, sir.
Yeah, you can increase the PIP. So how much area can be covered by increasing PIP? So this is a, you can then name it. What is the area increased by increasing PIP? There's a numbers for everything. Which number you're going to find out?
Area 2.
2, sir.
You're talking about this area. This is the area you're talking about, which can increase by increasing PIP. Any other thing?
Inspiratory time increase.
Respiratory time can be increased.
Can you name it? Can you name the number which can increase by increasing inspirated time?
1 and 3.
3.
Yeah.
3, sir.
Inspirated time you can increase just 3. You cannot increase 1. And for increase 1, what you need?
P rise.
What you have to do? T rise. You have to decrease or increase?
Decrease.
Decrease. Decrease.
Not increase T rise, because you need to make the slope more vertical. Then what other things you can increase?
P.
What is the number you can get by increasing P?
4.
Now you have to explain what is 5 here. So 1, 2, 3, 4 is clear. What is 5 here?
Expiratory time we have reduced.
Expected you reduce it. That is common, more like increasing inspirated time only. Once you reduce expected time, what will going to happen automatically? Either inspirated time going to increase or what is going to increase?
T total will be decreased.
So then what is going to increase?
Rate.
Yes, exactly. That is what you need to think here. If you don't alter inspiratory time and you decrease expiratory time, automatically your rate is going to increase. Or if you want to keep the rate same, you decrease E time, you're going to increase the I time. There's no other go. So that is fifth one is, you are correct, increase the rate, but you should not alter inspirated time. You have to keep same inspirated time. So then only you can increase the area on the map, but that parameter you don't use usually. That is the last result, and you will don't forget about it. Just remember this 4, 1, 2, 3, 4. Just remember this 1, 2, 3, 4. 1 is T rise, 2 is PIP, 3 is I time, 4 is PEEP. In this, I will tell PEEP is the most important thing. So we'll see how it's going to help us in different lung conditions. Okay, is it clear? So So what are the maneuvers you can do increasing this map is you increase the inspirator flow rate by decreasing the T rise. You can increase the PIP, you can increase the I time, you can increase the P, and you can increase the rate, but your I time should not change. The increased rate should compromise the E time, but you should not compromise the I time. That's the most important thing you need to remember. So these are the parameters you can change to increase map. By increasing map, what you're going to increase?
Oxygenation.
Oxygenation. That's directly proportional. If you have an issue with oxygenation, you need to touch the map. What to touch depends on underlying lung. We'll see it later. And you have one more most important concept here. So there's a question for you people. So you have two balloons here. One is a already very much collapsed balloon and little bit expanded balloon. And you need to make the two balloons to go to this size. So here, which balloon blowing is easier? So your collapsed, very much collapsed balloon or little inflated balloon?
Little
Why?
surface tension, sir.
Exactly. So you need to have more work to be done to increase to overcome the surface tension. So when you have collapsed balloon, all the molecules will be nearer and surface tension will be more. So that's why you need to do more work. When already stretched, they'll be separated and the surface tension will come down. So your work done will be less. So that's why you need to have a strategy called open lung strategy. So open lung strategy. So where there you need to keep all the alveoli open so that to distend them further, you need to do less work. So if you start making the alveoli collapse and again you need to expand them, you need to do more work. Same thing, if you distend the alveoli a little bit, you don't make the alveoli collapse further. And from there you start expanding the alveoli. That is easier. And the next question is how you to prevent this collapse. How you need to prevent this? What are the strategies you need to use to prevent this collapse? Or how to make balloon to make this?
PEEP, by increasing the PEEP.
Why you are not PIP?
PEEP is the expiration pressure, sir. That is what we want here.
Why? You need to explain it little. If you can explain it better, that means you understand it better. So there are two volumes we talked on day one class. On day one, we talked about two volumes. They are most important. That is the needed. That is the volumes which will make the lung collapse.
Closing volume and
Closing.
Yeah. Excellent. Closing volume and
FRC.
FRC. What is the relation between FRC to closing volume in normal lung?
always FRC is more than closing volume in a normal lung.
Then,
It is kept open.
what is the relation between in a disease like parenchymal problem?
FRC will decrease.
So it will collapse.
So your closing capacity is above the FRC and your lungs try to collapse. So now what is the main aim? What you want to do here? You need to get back your, what you want to get back? Here,
FRC.
FRC. Now what is the pressure needed to get back the FRC? What is FRC?
Functional residual capacity.
At the end of expiration.
Volume at the end of expiration.
The expiration.
So what determines FRC now? What pressure determines FRC?
PEEP.
PEEP determines the.
You know that PEEP is the pressure which will be there at the expiration. And FRC is the pressure of volume will remain at the end of expiration. So you need to give adequate PEEP to maintain FRC. So there's a concept called optimum PEEP. So you need to maintain the lung volume in certain extent that your FRC will be above the CCV, so lung will not collapse. So there's a disease pathology, and it is making the lung collapse because of low FRC. And our strategy, ventilation strategy, is to optimize the PEEP, which is the pressure which will determine the FRC, so that the collapsed lung will go back to this stage. Then you apply delta P to make the lung expand and generate tidal volume. See, from here also you can directly apply delta P. From here you apply delta P and you can increase this. From here also you can apply delta P, but which delta P will be higher? This delta P or this
And the
delta P?
collapsed therapy.
First
And
one.
collapsed therapy inflating will be more.
Exactly. So I give you example here. So this left side collapsed lung, your PAP is 25 and your PEEP is 5. So PAP is 25, PEEP is 5, and you're able to get normal saturations. And you have this side PAP 20 and PEEP of 10. Which you're going to choose? Your SATs are same in both pressures. PAP of 25 and PEEP of 5. One side, PAP of 20 and PEEP of 10. Which you're going to choose?
PEEP of 10 and THF.
Why? Why you will not? You are going not choose the other one? Because you need. Finally, you're going to need saturations and CO2s. You are able to get normal saturations and normal CO2 in both settings. You understood, right? My question is clear here. So your ventilation strategy is normal oxygenation, normal ventilation. You increase PAP. By increasing PAP, you're able to maintain saturation. That means you increase the MAP and you maintain saturations. Then why you are worried about that? Why you want to choose that high PEEP and low PAP strategy?
More FRC when the PEEP is high.
No. Come back again. The answer
The FRC will be
the answer is there in the first slide. Our main aim is not only maintaining oxygenation ventilation. What you have to, our other aim is
Protect the air.
What
Airway protection.
you have to prevent? That is indication. Strategy I'm telling. Lung is,
baritone should be prevented.
we'll discuss it later. Just tell me one word, lung injury, that's all. That's enough for me. That's barotrauma, volutrauma, biotrauma, all trauma, that will take talk later. Our main aim of ventilation, apart from maintaining oxygenation, adequate ventilation, is preventing lung injury. It is as important as you are maintaining oxygen. Don't just see the numbers. If you just see the numbers and you start using ventilation, you will cause more damage to the lung than if you accept low pressures, low saturations. That's what I'm telling. So here the most important strategy in collapsed lungs is you need to get back the FRC, because that is the physiological thing. And if each time the lung collapses and expands from here to here, you will stretch the contractile elements too much. That will cause atlectotrauma. Finally, it will lead to biotrauma. And your PAP is high here, so it can cause barotrauma. So these are the traumas you are inducing to the lung by just ventilating to maintain oxygenation, when you know this is not the correct strategy. That's why you need to optimize the PEEP first, and to get back the FRC to the normal, then you ventilate the lung with less pressures. So that is the. So many times I see many people asking me, when I'm able to get saturations, why I want to worry about increasing PEEP? Still is maintaining. I'm comfortable with low PEEPs. This is what I commonly encounter from the people. The high PEEP will cause pneumothorax. I don't want high PEEP. It is not the PEEP which is going to cause pneumothorax. It is the tidal volumes. And many times PEEP will over distend. When you go and keep on over distending the lung, you go beyond FRC. The PEEP will not directly cause anything. If the PEEP is not able to make even the FRC, it is not going to damage the lung. When you increase the PEEP too much and it crosses the FRC, then your lung will burst. Directly pressures will never damage the lung. It is the volume which is getting generated is going to damage the lung, causing pneumothorax. So it's causing air leaks. So high peeps, when in a stiff lung, there is nothing meant because it will get dissipated. But the same peep you give for a normal lung, you are increasing the FRC, it will burst. I think everyone understands what I'm talking. You are giving peep for a stiff
Yes,
lung,
sir.
you are getting back just to FRC, it's not going to cause pneumothorax. But if you increase the peep too much and you cross out the FRC, then it will cause damage. Because the same peep you are going to apply for the normal alveoli as well. So you are going to give peep for diseased alveoli as well as normal alveoli because your pneumonia is heterogeneous lung. It is not a homogeneous lung. You have diseased alveoli, you have normal alveoli. Once you start giving PEEP, it will go to both alveoli. One alveoli will reach into normal FRC. Alveoli which is at the normal FRC will be stretching more and it can burst out. So that's why you need to give optimum PEEP. It's not like you need to give high PEEP. It is the optimum PEEP. And how to select this optimal PEEP we'll do in the next class. But this class, you need to remember that in airway parenchymal problems like pneumonia, ARDS, HMD, the lung is collapsed. So you need a little higher PEEP than the normal PEEP what used routinely. Yeah, you need to discuss this PEEP titration, what is the optimal PEEP in subsequent class. And right now you remember that in child with a parenchymal problem, you need a little higher PEEP because you need to get back the lung to FRC. Just remember this one point. Parenchymal problem, with collapsed alveoli, you need to apply little higher PEEP. Little higher. I'm not talking about a high PEEP. Little higher PEEP. What is called optimal PEEP. And what is optimal PEEP? We'll see in PEEP titration in tomorrow class. And for this, we need to know what is main physiology in the lung disease. Without understanding the physiology, you cannot do the normal like ventilation easily. I think I'm clear on this slide. This is the most important slide. If you understand,
Yes, sir.
we'll move on to the next slide.
Yes, sir. Yes, sir.
There are two concepts now. You understand, right? One is map. So everyone knows what is map and how to increase map. Is it clear?
Yes, sir.
It's very simple. Just you need to just think. This is I'm not talking any difficult concepts here. It's very simple concepts. And just the only thing you should know is what is map, what is area under the curve, how I can increase the area under the curve. I have 4 parameters for increasing that. You just keep revising this diagram. That's all. And what is parenchymal disease? What is the problem in parenchymal disease? And what is the collapse of lung and how to open the lungs by giving optimal PEEP. So this is the other concept. So to summary, when you have a problem with parenchymal disease, what you're going to touch first to increase map?
PEEP. PEEP.
So these are the parameters you have 1, 2, 3, 4. Just give the number for me. Just no need to talk also. Just give the number for me. So if you have a parenchymal disease and airways are collapsed, alveoli collapsed, what is the first parameter you need to increase map?
4. 4.
First parameter.
PEEP.
PEEP. Why
4.
PEEP? No, just wait there. Why PEEP?
To maintain FRC.
Exactly. You know that the main problem there's no FRC. So you need to maintain the FRC by just giving PEEP. Even after maintaining FRC, you are not able to get the oxygenation. Then you need to increase the map further. So then what you have to do? You have 3 left. 1, 2, 3. What you have to choose next?
PIP.
No?
Inspiratory time.
Yeah. So inspiratory time, because you know this is the problem with stiff lungs. So you need to increase the map. The problem with the PIP is going to cause barotrauma. That's what I'm telling. You keep on increasing PIP, the chance for barotrauma you're increasing. So that's why the main aim for us is to minimize the total pressure. That is the most important thing. So to prevent barotrauma. So that's why you need to increase the I time. So first parameter is PEEP, second parameter is I time, then
PIP.
yeah, then you can go for PIP, T-rise, and last thing is rate without
Rate.
like the I time. That is very last thing. Don't just forget about that. So in the order of 4, 3, 2, 1. Just remember this. You have a parenchymal problem. Your order is 4, 3, 2, 1. So start with PEEP, go with I time, then PIP, and finally inspiratory time. If your PIP is too much, then I won't touch it first. First I go for T-rise, then I'll come back to PIP if still I am not able to maintain oxygenation. So 4, 3, 2, 1. Is it clear?
Yes, sir.
Then what is the problem with high resistance? Why the child is desaturating in high resistance? Why the child should desaturate in high resistance?
Inspiratory pressure not sufficient.
Actually, the pressure needed to overcome the resistance is not sufficient. So, what is the FRC in airway resistance? They'll have normal FRC, low FRC, or high FRC.
High.
High
High
effort.
FRC.
Why? How you are telling? How they look on X-rays?
Hyperinflated.
Hyperinflated.
Be hyperinflated. That's why your FRC is high. So, when a child with asthma is desaturating, what are the things you need to increase MAP?
PIP we should increase.
Okay?
PEEP decrease.
No. Don't confuse yourselves here. I'm just asking how to increase MAP in airway. We'll discuss all the other parameters later. But here I'm talking about MAP, the concept of MAP, which is going to control the O2. Any child with low saturations, you need to increase MAP. That's all. What is the initial MAP in airway will come later. We'll see it in subsequent slides. So my point here is, you already put the child on ventilator. Child is having low saturation on ventilator. So what are the things you're going to change to increase the SpO2? That's what my question here. So to increase SpO2, what are you going to increase?
PIP and T-rise.
MAP. So in MAP, what you're going to adjust is PIP and T-rise.
T-rise.
Why not PEEP? Why not I-type? No, you tell me. Why not PEEP?
Here, FRC is not a problem.
Already FRC is high. What is the point of increasing PEEP here?
Yeah.
So why not I-time? I-time can increase MAP, right?
But already hyperinflated.
It's okay. Then why are you increasing PIP when child is hyperinflated? When lungs are hyperinflated, why are you going to increase PIP?
We should allow expiration also.
Exactly. If you increase I-time, what will happen to expiration time?
It will
Decrease,
decrease.
Automatically.
Will decrease.
Yeah. So when you know the problem in asthma is they're not able to get rid of the air out.
Air trapping.
Yeah, you can increase the pressure, you can push the air in, but you cannot get the air out because the ventilator, we cannot do the work. The work to be done by the patient only there. So that's why never ever increase I time in asthma. That's what I'm going to tell. Don't touch PEEP, don't touch I time. You have only two options left, that is PIP and T-rise.
T-rise.
Okay, this is a summary slide for that. So you have problem with parenchymal, you have a lot of options, but you have a problem with airway, you have only two options, nothing, PIP and T-rise. Is it clear? Can we move on?
Yes, sir. Yes, sir.
Next question is how to improve ventilation. Ventilation is nothing but CO2. How to normalize CO2.
Tidal. Respiratory rate.
Yeah, combine them.
Minute ventilation.
Other parameters, non-ventilator parameters, what you can control to improve ventilation.
Dead space.
Yeah, get space. And you can increase E time. So cut the tube, remove the extra accessories. And finally, the only option you left after all optimizing this is HFOV, because their expiration is active. So only where the expression is active is HFOV. So ventilation issue, that is PCO2. The PCO2 is inversely proportional to minute ventilation. So oxygenation is directly proportional to
Yes.
MAP. That is the one word I have to hear at the end of this class. Don't talk about PIP. So don't confuse yourself. Oxygenation is proportional to MAP. So when I have low saturations, what I have to do?
Have to alter the map. Change. Map.
You need to increase MAP. Or alter means different. You need to be very specific. If I have low saturation, what I have to do?
Increase map.
That's all. Don't tell alter. Alter can be, you can decrease the MAP also. Don't be very specific. I have low saturation and increase the MAP. How to increase MAP depends on the underlying lung disease. But any lung which is having low saturations, you need to increase the MAP. That's all. There's no other concept for that. But how to increase the MAP based on the 4 parameters, what you're going to touch first is depend on the underlying lung disease. Same, you have a CO2 issue. So in CO2 is inversely proportional to minute ventilation. Minute ventilation is tidal volume into respiratory rate. That's all. Now the main question is what to touch first. Whether you want to touch tidal volume or you want to touch respiratory rate first.
Respiratory rate.
Why?
Tidal one.
Why? I need answers. If you want to touch tidal volume first, give the answer. If you want to touch rate, give the answer. Someone told rate, someone told tidal volume. So why you want to touch rate first, not tidal volume? And if answer is tidal volume, why tidal volume first, not rate? It's all about preventing lung injury only, man. I'm just asking a simple question. So tidal volume, you need to prevent polytrauma. So tidal volume is proportional to MAP actually. And you need to more concentrate on expected time. And you cannot keep increasing respiratory rate beyond physiological rates. So why?
Expiratory time will decrease.
Exactly. So don't go beyond physiological rates. And the most important concept here is if you are on lower parameter, like your respiratory rate for a 6-year-old child, already you are on 30. And your tidal volume is on 5 ml per kg, which is the one you are going to touch first. Tidal volume, because you are already on the extreme verge of respiratory rate. If respiratory rate is 20, tidal volume is 5 ml per kg, what is going to touch first?
Rate.
Yeah.
Respiratory rate.
Up to which you can go respiratory rate in this child?
Physiological.
Physiology.
6 years old, I'm just asking, 6 years old, you are on 5 ml per kg tidal volume and 20 rate. And your CO2 is high. So what you told, you are going to increase the rate. How much? How much you are going to increase? You're going to increase 1 or you are going to increase certain extent?
Quite good.
Come again?
Right.
Use some number, mate. It's not going to be anything. I'm not going to be an examiner.
5.
Are you?
Usually will you 3 to 5. So if you tell 5 also not a problem. In newborns where you have lot of scope increase, you start with 5. In children where your scope is less, you can start with 3, even if 5 is not a wrong answer. Say, I agree with you, I increase it 25. Still CO2 is high.
We can rise up to 30.
You want to rise up to 30 in this child? Everyone agree with that? Everyone agree with this answer, or you want to do it something different? Now, the concept here is you need to keep the both parameters in the physiological ranges. When you have a tidal volume which is way low, your starting tidal volume is 5 ml per kg and ending is 8 ml per kg. And you are only your starting tidal volume. And you are reaching the rate almost the midway. If you have a rate frequency of 20 to 30, you are at 25. And without optimizing tidal volume, why you want to go to severe, very high rates? Is it clear what I'm telling?
Yes, sir.
So in the second situation, when you reach the rate of 25, still CO2 is high, you should not touch rate there. You should increase the tidal volume there. So you reach a tidal volume of 6 to 6.5 ml per kg. Then still CO2s are high. Then what you can do?
Increase the rate.
Yeah. So this is what you need to follow. This is a rough guide. There is no hard and fast rule for this. If I want to increase rate into initial to 6, fine, I am correct. I am at 6 ml per 5 ml per kg and the respirator of 20. Always I have a chance. I can increase it to 6 ml per kg initially itself. No need touching rate. Because I am not on the higher volumes. I am on the very basic volumes. So if you increase the volume initially itself, you are not wrong. And increase the rate initially also, you are not wrong. That's what I'm telling. When the both parameters on the lower side, you can choose anyone depending on your comfort. But if already a parameter is moving up and other parameters way below, don't keep on increasing only one parameter. You need to keep moving both together. That is what the main concept here. So you need to keep moving the things little up till you reach the maximum things. Once you reach the maximum things, what increase? I don't know. So you need to accept certain high CO2s. That is called permissive hypercapnia. We accept it. When you reach already the maximum things, you need to accept the permissive hypercapnia. And when you already increase the PAPs, PEEP, everything increase it, and still oxygenation is low, you need to accept permissive hypoxemia. What is permissive hypercapnia?
We keep CO2 level
CO2
at
up to
higher
50.
extent.
How much?
55 to 60.
How much?
100.
55 to
There is no number for permissive hypercapnia. What is the number you need to see? It is not CO2. You need to see other number.
pH.
Yeah, it is the pH. It is not a CO2 at all. So we'll try to keep the pH above 7.2, and if you're very much concerned, you can keep it 7.25. If the CO2 is 100 also, your pH is more than 7.25, accept it. That is called permissive hypercapnia. And what is the absolute contraindications for permissive hypercapnia? Up to absolute contraindications. You cannot allow CO2 high in this particular patients.
Raised ICT.
Exactly. 100%. Another indication? Other disease where you cannot allow high high CO2s and low O2s. I give the clue.
pH.
Yes. So these are the two conditions where you should not follow permissive things. You need to strictly maintain. Whether you damage the lung, I'm not going to bother, but you need to maintain the brain, other vital organs in pH by improving the oxygenation. So when you keep on increasing respiratory rate, you're going to decrease the E time. So you cause the incomplete lung emptying. So that is the main problem. But again, the CO2 buildups. So that is, you will be commonly seeing, you keep increasing rate and certain extent, you keep increasing the rate. your CO2 start building up. We think, why is the CO2 building up? I increase the rate. The formula is minute ventilation. CO2 is minute ventilation. Why is a problem? So expiry time is becoming shortened. Expiration is passive. During inspiration, you can increase the pressure, you can push the air in. But during expiration, if you don't give adequate time for expiration, your CO2 will build up further. So there is a relation between minute ventilation and gas exchange. So you see here, you drop the minute ventilation, your CO2 will exponentially increase, and you keep on increasing your minute ventilation, and to a certain extent it reaches the plateau. It cannot change further. So in patients with hypoventilation, even if you change small, there is already they are on the verge of low minute ventilation. Even if you change a little bit, so see here from 5, from say here some 3, child was on the minute ventilation of 3 liters. What is the CO2 here? Almost like 80. And you increase by 1 liter. That's all. From 3, you make it 4. How much drop you see? From 80, the CO2 drop to 40. So this is what you need to remember. In hypoventilation syndromes, even a smallest increase in minute ventilation can make a difference in CO2. You don't need to keep on increasing beyond the normal physiological rates. So just to maintain the physiological rate, that is enough for them. And just provide adequate tidal volume as well. When you crosses that, and already in higher minute ventilation, if you change maximum 5 to 6 liters also, you cannot get desired effect, much effect further. So that's the main problem. So the easier thing is in hypoventilation child, increase the minute ventilation by little extent, you can get a dramatic response in CO2. That's what they will get completed normalization CO2s. But if already our child on very high minute ventilation and child is still high CO2, there's a problem with the lung, and it's going to be difficult for you to get the desired drop in CO2s further. So finally, the disease-specific ventilation, you have 3 scenarios. One is the bad lungs, I think the bad airways, and normal lungs. Bad lungs are pneumonia, ARDS, and HMD. Bad airways are bronchiolitis, asthma, and some forms of meconium aspiration. And normal lungs, mainly CNS conditions and post-operative conditions. These are the main 3 scenarios. And this is the ventilation strategies. This summary slide. So normal lungs, keep everything normal. Don't do anything extraordinary. In bad lungs, you need to restrict your tidal volumes. This is a concept called baby lung. So baby lung, so the concept is the lung is, some part of lungs are damaged. And what is that remaining lung is, which is a normal lung. So you should not give tidal volume, more tidal volumes, because already collapsed alveoli will not take the volume. And this entire volume is going to the normal alveoli. What they will happen to them?
Volume trauma.
Volume trauma, air leaks, and all will happen. So that's why you should restrict the volume. So you have to think that I am not ventilating the collapsed alveoli. I am ventilating just the normal alveoli, which is very much less. That is the concept of baby lung. So you need to target only on the ventilating the normal part of the lung. And you need to optimize the PEEP. You need to give little high PEEP to open the collapsed alveoli, and you should not over distend the normal alveoli. So 2 things simultaneously. When you're giving PEEP, you should not over distend the normal alveoli, and you need to try to just to open the collapsed alveoli. You should not make them normal. I'm not talking about you should make them normal. So you should just open the normal collapsed alveoli, and you should not over distend the normal alveoli. If you over distend, what will happen? Simultaneously, it's going to make the already diseased alveoli collapse. Normal alveoli distend, there is no space for the expansion of the lung, and finally the pressure is going to put on the diseased alveoli, they will collapse further. So that's why you are not going to achieve your desired effects. So when you keep on increasing PEEP, again your SATs will drop. To a certain extent, they will rise, again they will fall. So that you should know that, no, I am crossing the border. I am doing the overventilation. So I need to cut down the PEEP. So in bad lungs, so you need to restrict your tidal volume. you need to give little higher PEEP. What is higher PEEP? We don't know. For you should optimize it for the underlying lung. Don't go by the numbers. So which lung needs how much amount of the PEEP? You don't know. There is no fixed number for. You should not cross 10 PEEP. You should not cross 12 PEEP. We have ventilated a child with even 18, 20 PEEPs as well in severe ARDS. So without any pneumothorax. But you need to be very careful when you're giving high PEEPs. That means you are also causing hyperinflation of the normal alveoli, if at all they are there. But usually, if you're needing that much high PEEP, means your lung will be already homogeneously white. That is a situation where you need really high PEEPs. You have very white lungs, completely from top to bottom, it will be white. So that's why there is no option. You need to go for higher PEEP because there's 99% alveoli already damaged. So there's no point of further worried about damaging the further normal 1% of normal alveoli. There you need to maintain the oxygenation to the vital organs. And usually, if you do correctly the ventilation strategy, you can prevent the lung to progress to that extent as well. But if the virus or what are the pathology which is causing ARDS, which is worsening, you don't have. But you should not add to that insult. It is already getting an insult, and you do the wrong ventilation strategies, and you cause further damage to the lung, and it will add up to the already undergoing damage. So then they will not recover back. And what is the item you are going to give here? So little longer item. What are the IE ratios? What is the normal IE ratio?
1:2.
1:2.
Yeah, 1:2. So what is the IE ratio you are going to keep here? So you start with 1.5, move to 1:1, and even very bad ARDS, you can go for the inverse ratio. Inverse ratio is 2:1. So is it clear for bad lungs? So your tidal volume, low tidal volumes. In severe ARDS, you'll target even 4 ml per kg, not even 6. You'll target 4 ml per kg. We'll go down. We'll cut down our targets. We'll go down to 6, 4, from 6 to 4 also. And one more important thing is you need to restrict your PIP. Your PIP should not cross beyond 30. And your P plateau. What is P plateau?
At the end of inspiratory
After
work.
after the resistance, airway resistance is.
Yeah, you stop the flow during inspiration so that you remove the work done for overcoming resistance. So whatever remaining pressure needed is to distend the alveoli. That is the alveolar distending pressure. That is delta P plateau. P plateau is alveolar distending pressure. The problem here is low compliant lung. So for low compliant lung, work done is to overcome the resistance, or work done is to overcome the elastance.
Resistance.
Come again, think. Resistance is for airway. Elastance is for the alveoli.
For elastance, more work.
Elastance more work.
So when in low compliant lung is parenchymal lung. I'm going to use the terminology interchangeably because you should understand it. Bad lungs, parenchymal disease, low compliant lung, all are same. Bad airways, hyperinflated lungs, air trapping, all are same. So in bad lungs or low compliant lungs, the main problem here is to overcome the elastance, not resistance. So that's why you need more P plateau than PIP. So PIP, that is the airway pressure, trans airway pressure. So overall, PIP will be high in both. In bad airways also, in bad lungs also, PIP will be high only. But in bad airways, what will P plateau? When compared to PIP, what should be the difference between PIP and P plateau? Just one. sorry. So what is the difference between PIP and P plateau in bad lungs? Already yesterday I showed the graphs.
Low decrease.
Low.
That
Low.
low there, and the normal difference is around 5. If it is the same 5 or a little less, that is bad lung. And you have a high PIP, and the difference is around 10 to 15. That means
Airway.
it's problem with airway. Even in airway problem, when you are having already a lot of air trapping, you need to do more work to distance alveoli also, because alveoli is already distant already. You understand, right? They will not have normal P plateau like normal lung. They are already distant alveoli. To distance them further, you need to do more work only. Apart from that, you need to do extra work for overcoming resistance. That's why your PIP will be much higher when you're ventilating for bad airways than bad lungs. The main thing is you have a difference between PIP and P plateau very high. That tells you that this is a bad airway.
It is only airless problems. There is no downtime.
Yes,
Then also we need to put high PAPS.
definitely. That's what I'm telling. You need to overcome the resistance because resistance is already high. You need to have high PIP. And always are distended. Once they are already distended, you have to do more of the distance further. Because there's no space in the lung to expand further. Your balloon is too much distended and it's already filling the room, entire room. To inflate it further, how much pressure you need? You need to do more pressure. That's what you need to have more PIP. To send the fresh air in. Whatever distension is on the old air. Old air is divide of oxygen, more of CO2. That's why sats are low. To increase the sats, what you have to do? You increase the PIP. Why are you increasing PIP? Because to overcome the resistance, to overcome the distension. Without sending fresh air in asthma, you cannot get the oxygenation. So in bad airways, you need to have high PIP. Your volumes will be roughly 6 to 7 ml per kg. And like someone told previously, you need to give low P because your FRC is way above. So you don't need that much FRC also. So you should cut down your, usually we'll start with 3. And what is the I time here? It will be very short. You need to keep very short I time, low E time. And what will be the rates here in bad airways? What is the normal rate you're going to keep in asthma?
Less.
Physiological, lower physiological, high physiological, or below physiological?
Lower physiological.
Low physiological.
Below physiological.
Low physiological.
No, it's below physiological. It's almost near to low physiological to below physiological. So you start with very less rates. In asthma, if it's a typical case of asthma, you start at very less rates. Even it go below physiological. That is fine. So the rates you should never increase rates for increasing CO2 in asthma. That's the one thing you should remember. You should never increase rate for increasing CO2. So decreasing CO2. If you have a child in asthma on ventilator and you have high CO2s, you are already on like 7 to 8 ml per kg tidal volume. What are you going to do now? Problem is with CO2 here. You should remember CO2 is inversely proportional to unit ventilation, tidal volume. So you are already on tidal volume of 8 ml per kg. Your rate is say around 12 or 15 for a 10 years old child. Say 15. So what you are going to do now?
Increase rate.
Expiratory time we can.
So that is what I'm telling. Don't touch rate at all. Again, you are thinking that tidal volume into respiratory rate is minute ventilation. So I need to increase minute ventilation, decrease CO2. No. You need to decrease the rate here because you need to prolong the expiration. You know the problem here is the gas in the lungs are not coming out. That's why your CO2 is building up. It's not the problem with the sending fresh air. If you have low oxygenation, then you need to think about increasing pressures, increasing volumes. When you have adequate oxygen, that means you are sending the fresh air in adequately. But your CO2s are going to build up because you are not able to remove the old air out. So you need to decrease the rate, increase the E time further. You make it 1:3, 1:4, 1:5. Is it clear? Never ever increase rate in asthma for high CO2. If you're already on rate and CO2 is still high, you optimize all the other things, tidal volume, you should decrease rate. And sometimes if you still child is not able to maintain that and its lung is getting hyperinflated too much and it's compromising your hemodynamics, you need to discard the patient from the ventilator and squeeze the chest also to let out the already stagnated air there. So you do it manually. So when you've done all the measures and still the child is collapsing, you need to compress the chest to allow the air to go out. Is it clear? This is summary. So normal lungs, bad lungs, and diseased lungs. Diseased airways. So there are two special circumstances like raised ICP. So in that you need to optimize certain perfusion by increasing the MAP, not ventilator MAP, your normal blood pressure, mean arterial pressure. And your targets here, the strict targets, you should follow strict targets. Your PO2 should be above 80. Your CO2 should be below 40 and it should not go below 30 and all. So you need to maintain a normal range. So 35 to 40 is the tier 1 target and PO2 should be between 80 to 100. And you need to keep the PEEP on low normal side. You should not increase the PEEP. Why? Why you should not keep on PEEP on higher side?
Because high peak
Decrease
will
the
decrease venous
cardiac
rhythm.
High peak will decrease the cardiac venous rhythm, cardiac.
You decrease the venous rhythm first.
Venous rhythm.
And also it's going to decrease the hemodynamics, perfusion. So MAP, BPs. So that's why your cerebral perfusion is going to come down. So that's two ways it's going to be detrimental in rigid ICP. That's why you should target on the low normal side. You should not go up on the normal, even high normal PEEPs. And in DKA, you need to match the CO2 values before intubation. That's all. That's the one concept you should know. You should not normalize the CO2. If you normalize CO2, that means you are decreasing the pH further and child can collapse. If it is unfortunate to ventilate a DKA child and if the child is having raised ICP signs and you are ventilating a child, your strategy for CO2 is what is the pre-ventilation CO2. So till that time, you should hyperventilate a child. You increase the rate, you increase the tidal volume, you do whatever you want. But your CO2 should be to the value of pre-intubation CO2. If your pre-intubation CO2 is 15, you need to do the ventilation to get the CO2 back to 15. By managing the child with insulin fluids and slowly your pH is building up, then slowly you can liberalize your CO2. From 15, you go back to 18, 20, 22. Like that, you need to build up, but not at the go. At the go, if you increase the CO2 normal, from 15, you make to CO2 to 35, gone. Your child is going to have cardiac arrest. Now from 6.9 pH, you intubate a child with a CO2 of 15, you make the CO2 35, what will happen?
Acidosis will worsen.
Your pH will from 6.9 drop to 6.7 and child will have a cardiac arrest. So that's why ventilating a DKA child is very important. When you're intubating, you should maintain adequate minute ventilation during the process of intubation also, because you use apnea, you're not able to ventilate a child or you're not able to intubate a child, gone. So that's why you need a very senior person for intubating DKA child. You need to be well versed with ventilation, how to tackle that situation. You need to keep giving hyperventilation through bag and mask, and you should not delay putting tube. The more prolonged apnea can cause cardiac arrest. So we'll discuss all these things in subsequently in RSI and intubation difficult airways class. And this is the end for today's session.